We will discuss about OHSS. References are RCOG 2016-2024, Gardner textbook, and ASRM 2016 guidelines. Okay, so OHSS is a serious condition that occur in the woman undergoing fertility treatment, particularly ART, like IVF. Okay, it happens when gonadotropin can even occur in normal doses. Okay, gonadotropin normal doses also OHSS can occur. So it occurs when gonadotropin, which are the hormone used for control ovarian stimulation, led to excessive response from the ovary. Now ovary started having excessive response. Okay, that's why this happened. The key trigger for OHSS is HCG, which is a hormone that is structurally similar to LH, but half-life of HCG is 24 hours, and half-life, which is much more than LH. Half-life of LH is 60 minutes. This long-lasting effect of HCG plays a crucial role in developing OHSS. So when the ovaries are hyperstimulated by the exposure of HCG, they start producing pro-inflammatory mediators, which are chemicals that causes swelling, inflammation, and increased fluid leakage from blood vessel. This led to ovarian enlargement and other systemic effect, such as fluid accumulation in the abdominal cavity, or even fluid even collected in the lungs in severe cases. Okay, fluid collection. How common OHSS is. Moderate to severe OHSS is not very frequent, occurring in about 1 to 5% of the stimulated cycle. 1 to 5% of the stimulated cycle. However, the exact incidence is difficult to measure because there is no single strict definition that applies universally. Okay. Now, what pathophysiology, what happens? In this condition, small vessels around ovaries expands, a process known as arteriolar vasodilatation. At the same time, the wall of small blood vessel called capillaries become more porous or leaky. Okay, walls become more porous or leaky. This increases the capillary permeability, allowing fluid from blood vessel to escape into the surrounding tissue. As a result, fluid moves from the blood vessel to the blood vessel, that is intravascular space, to the surrounding tissue, that is extravascular space. This fluid shift causes condition known as hypovolemic hyponatremia. Hypovolemic hyponatremia, where the volume of fluid in the blood decreases and sodium level in the body drops. Okay. Hypovolemia means blood volume decreases. Hyponatremia means sodium level drops. The most important player in this process is VEGF. VEGF is vascular endothelial growth factor. This is a pro-inflammatory mediator that increases the permeability of the blood vessels and has a direct correlation with the severity of OHSS. Okay, in simple terms, the more VEGF in the body produces, the more severe the condition is. Okay, VEGF is also involved in normal physiology or normal processes like follicular growth and angiogenesis, like formation of new blood vessel. However, it's not just VEGF that plays a role. Other chemicals and hormone, including interleukin 6, interleukin 1 beta, angiotensin 2, insulin-like growth factor 1, transforming growth factor beta, and RAS, renin angiotensin system, also are also part of this complex process. Together, these mediator causes the clinical features of OHSS. Okay. Now, additional factor that involved in OHS, apart from these mediators, certain other hormones and substances are also implicated in OHSS. These include HCG analog. HCG analog means any synthetic form of HCG which is used in treatment. Second is estrogen and estradiol. Estrogens, okay? Second is estrogens. This is a female sex hormone. Third is prolactin. This is basically called a hormone associated with milk production. Fourth is histamine. This is involved in allergic reaction, histamine, okay? Fifth is prostaglandin. Prostaglandin. This is involved in inflammation. Now we'll talk about this diagram. See, OHSS can be mild, moderate, severe, or critical. Severe forms can lead to complications like fluid accumulation in the lungs, pulmonary edema, blood clots, kidney failure, and even the life-threatening conditions if not managed, okay? The understanding the cause and mediator of OHSS is essential for clinician to prevent and manage it effectively. Now, this diagram explains the entire process of the OHSS. HCG and LH hormone stimulate the ovary. HCG and LH hormone stimulate the ovary. It led to increase in sex steroids, release of inflammatory mediators like VEGF, interleukin 6, TNF alpha, and TNF beta, and another is RAS activation, renin-angiotensin system activation. All these factors contribute to the neoangiogenesis, that is formation of blood vessels, and endotheliosis. Endotheliosis means damage or swelling of inner lining of blood vessels, making them dysfunctional and more prone to leaking. Till here, understood? Then as a result, capillary permeability will increase. As a result, what will happen? Capillary permeability will increase, causing fluid leakage. Okay, capillary permeability increase, causing fluid leakage, which will cause ascites, pleural effusion, means, and hypovolemia. That is low blood volume. This led to blood thickening. This will lead to blood thickening, that is hemoconcentration. And systemic inflammatory response. Which can lead to organ dysfunction and severe complication like kidney failure. Okay, kidney failure means oliguria and anuria will happen. Kidney will fail. Then infection. Then blood clot means thromboembolic complication will occur. Then lung failure. So ARDS can occur. And ARDS is acute respiratory distress syndrome. Now we'll talk about another diagram. See, this diagram explains how VEGF is involved in OHSS. The process is divided into two sections. First is A section. Second is section B. First section will talk about granulosa cell and VGF production. The ovaries become hyperstimulated. Ovaries become hyperstimulated, leading to multifollicular development. See, multiple follicles are developing. Okay. Inside the follicle, granulosa lutein cells are present. See, inside the follicle, granulosa lutein cell present, which have HCG receptor on their surface. These granulosa lutein cells are having HCG receptor on their surface. This is HCG receptor. So HCG bind to these receptor. HCG molecule bind to these receptor, activating VGF gene expression. See, VGF gene expression is activated. Okay, this result in production of VGF mRNA, which led to the synthesis of VGF protein, and VGF is then released into the bloodstream. Now, what is VGF effect on blood vessel? When second part we are talking about now, B part. Now, what VGF will do is, VGF, when HCG stimulate the ovary, it not only increases VGF production, but also upregulate VGF receptor 2. Okay, mRNA expression. So this means that the body produces more VGF2 receptor on the endothelial cell of the ovarian blood vessel. So now VGF is secreted from the granulosa lutein cells, as we have already seen, and binds to its receptor, VGF receptor 2, on the endothelial cell of the ovarian blood vessel. See, this is ovarian blood vessel. It is binding to the endothelial cells of the VGF receptor 2 of the endothelial cells of the ovarian blood vessels. Okay. So, this causes loosening of the cell junction, making blood vessels more permeable. Fluid start leaking out of the blood vessels into the surrounding tissue, leading to fluid accumulation, that is ascites, pleural effusion, and pericardial effusion, hypovolemia, and hemo concentration, that are key features of OHSS. See, loosening of cell junction occur. Okay, so fluid extravasation will takes place. Now here we'll talk about VGF mediated pathogenesis of OHSS. See, HCG will act on the granulosa lutein cell. I have already told. Granulosa lutein cell will increase the VGF mRNA expression, which will increase the VGF production. Even granulosa lutein cell will also increase the VGF receptor 2 mRNA expression, which will produce VGF2 receptor on the capillaries. Now, these VGF and VGF2 binds and increase the vascular permeability, which causes OHSS. Now, we'll talk about this diagram. See, there are two types of OHSS. One is early OHSS and another one is late OHSS. So early OHSS occurs due to exogenous HCG, the HCG which injection used in the fertility treatment, which we have given from outside. Okay, and late OHSS caused by the endogenous HCG, that is HCG produced naturally by body, often after pregnancy occurs. Okay, both type led to hyperstimulation of the ovary. See, ovarian hyperstimulation. And what will happen? This will, in the hyperstimulated ovarian follicle, RAS inside the ovary become highly activated. RAS will become activated in the ovary. So what will happen? This led to increased production of angiotensin 2, which plays a role in vascular permeability and inflammation. RAS will get activated because body thinks that it has lost water and there is hypovolemia. So RS will get activated, okay? Because body will think there is hypovolemia. So RS will get activated. So renin converts angiotensinogen to angiotensin 1. Then angiotensin 1 is converted into angiotensin 2 by ACE, and angiotensin 2 is responsible for vasoconstriction. So basically, angiotensin is due to vasoconstriction. So basically, body tries to fix the hypovolemia. Okay, so that's why it is activating RAS system. But actually, water is there, but water is leaking, which falsely, because of which body falsely think that there is less water in the body. So there is a leakage. Okay, water leakage. Though there is water, but there is water leakage. Now, because of RAS, body will hold more water to compensate for perceived fluid loss. Okay, but since there is leakage, fluid shift continues, more fluid buildup will be there in the wrong places. The wrong places like abdomen, abdomen, आपका ये pleural effusion will be there, ascites will be there, swellings will be there. Okay, and there will be blood thickening because of the vasoconstriction. Blood thickening will be there, hemo concentration will be there. Okay, which can increase the clot risk. So RAS tried to correct dehydration but ends up making OHSS symptoms worse by retaining more fluid. See, by the flow chart, you can understand OHSS causes fluid shift. Okay, fluid moves to abdomen and lung. Ascites, pleural effusion occur. Body thinks it's dehydrated, hypovolemia. So RAS system get activated. So renin is released, angiotensin 2 is released, aldosterone is released. Basically, these all are retaining water in the body. So increased fluid retention will be there, but fluid still continues to go out. This will worsen the OHSS symptom. There will be more swelling, ascites, pleural effusion, and angiotensin will constrict the blood vessel. This will cause blood thickening and clot risk. Then cycle will continue and worsening the OHSS. So basically, RAS and VEGF is contributing to the OHSS symptoms. Now another diagram explained here. It is talking about the same exogenous HCG act as a trigger. RAS and VEGF acts in the blood vessel, which worsens the OHSS symptoms and increase the vascular permeability. There will be loss in the fluid in the third space, that is ascites, pleural effusion. There will be hemo concentration that will cause thromboembolism. There is hypovolemia and electrolyte imbalance, which will cause hepatorenal insufficiency. Another diagram, release of vasoactive system also contribute to the third space loss of the fluid. So tissue edema will be there and hypovolemia will be there. Tissue edema will cause ascites and hydrothorax, which can cause compartment syndrome. Hypovolemia will cause decreased organ perfusion, which can cause liver and renal impairment. And hypovolemia can also cause hemoconcentration hypercoagulability. This will cause thromboembolic event. There will be clots in the body. Okay. Now this diagram we can see ovulation induction, pregnancy, and luteal support. Means luteal support if done by HCG. Okay, pregnancy HCG will be secreted in pregnancy, and ovulation induction also there will be HCG role. Okay, these all will increase the HCG, and there is endogenous LH surge in the cycle. So their VEGF will increase, which will cause increased permeability and ovarian hyperstimulation syndrome. Now these ultrasound images shows OHSS. Image 1A shows enlarged ovaries with multiple large follicles, fluid filled a classical sign of OHSS. And this fluid is also seen. See, fluid is there. And see, this image B, free fluid in the pelvis. This black area is all free fluid in the pelvis. This is uterus. Okay, this is uterus and this is endometrium. So this black area is all fluid, indicating fluid leakage due to increased vascular permeability. So now let's discuss the risk factors that increases the chances of developing OHSS during fertility treatment. First is demographic factor, which include age, BMI, ethnicity, and infertility causes. So basically, women aged younger than 35 year are at higher risk of OHS. This is because younger ovaries respond more aggressively to the stimulation. Okay. Second is BMI. Lower BMI may increase the risk of OHSS, but research finding on this is not entirely consistent. Third is ethnicity. Studies have shown that there is high prevalence in the of OHS in the women of Black ethnicity. Fourth is infertility cause. Certain conditions like PCOS is a significant risk factor. Other factors include ovulation. PCOS is a risk factor. Other factors include ovulation disorder, tubal factor infertility, and idiopathic infertility, that is an unexplained infertility. These also contribute to the risk of the OHSS. Now, ovarian reserve marker, there are ovarian reserve marker like AMH, AFC. We'll talk about 3 ovarian reserve marker: AMH, AFC, and inhibin A and B. So AMH level above 3.36 nanogram, indicate a higher risk of OHS as 3.36, okay? And level greater than 5 nanogram per ml significantly increases the risk, while values above 10 nanogram per ml are linked to threefold increase in the OHSS rates. Now AFC. An AFC of greater than 24 follicle is strongly associated with moderate to severe OHSS. The higher the AFC, the greater the risk. Then inhibin A and B. Interestingly, there is no direct correlation between inhibin A and B levels and OHSS according to current research. Now we'll talk about ovarian stimulation parameters. See, follicular count having greater than 20 growing follicle, growing follicle means greater than equals to 10 millimeter, or greater than equals to 18 large follicle, greater than equals to 11 millimeter, increases OHSS risk. Okay. So higher follicle count indicate greater risk for severe OHSS. Second is oocyte retrieval. Collecting greater than 24 oocyte during IVF cycle is strongly linked to OHSS. Now, semen estradiol level above 2,500 picogram per ml are considered a warning sign for OHSS, while level exceeding 3,500 picogram per ml are commonly seen in the patient with developing the symptoms. And now we'll talk about the unusual cases. See, OHSS can present in unusual cases. Unusual instances include spontaneous OHSS, which may occur in cases of multiple pregnancy, molar pregnancy, hypothyroidism, and FSHR gene mutation. Okay. Multiple pregnancy, unusual cases of OHS we are talking about. Second is molar pregnancy. Third is hypothyroidism. This is thyroid gland, hypothyroidism, and FSHR gene mutation. Additionally, OHSS has also been observed after ovulation induction with clomiphene citrate, even without ART cycle. Okay. Now, We'll talk about clinical features of OHSS include symptoms such as nausea, vomiting, diarrhea, reduced urine output, three, nausea, vomiting, diarrhea, then reduced urine output, then abdominal bloating, then mild abdominal pain, tension, increased ovarian size and ascites, hemoconcentration, hypercoagulability, electrolyte alteration, classified by Asrm into mild, moderate, and severe category. Now we'll talk about the timing of the symptom of onset. Further categorize OHSS into early OHSS and late OHSS. Early within 7 days of HCG trigger due to excessive ovarian response. Late OHSS occur 10 days or more days post trigger linked to endogenous HCG from early pregnancy. Late OHSS is more severe and prolonged. OHSS is usually self-limiting in nature. In non-pregnant women, it resolves by next menstrual period. Okay. However, in pregnant women, symptoms may persist until the end of first trimester, driven by ongoing HCG stimulation. It is crucial to exclude other conditions with similar symptoms, as OHSS is rarely linked to severe pain. There is no severe pain. It is not linked to fever, rarely linked to fever or signs of peritonitis. We have peritonism. Okay. OHS is rarely linked to these signs. So differential diagnoses include pelvic infection, abscess, appendicitis, ovarian torsion, cyst rupture, bowel perforation, or ectopic pregnancy. Importantly, OHSS should not be considered default diagnosis for women presenting with abdominal pain during infertility treatment, and other condition must be ruled out. Now, Rcog consultation document 2024 we are talking about, okay? Initial assessment and history taking for suspected OHSS. What all we'll ask the timing of the onset of symptoms related to trigger, because we want to know either it is early OHSS or late OHSS. Early OHSS occur within 7 days. Late OHSS happens after 10 days. Then pituitary download. We'll ask if the protocol GnRH agonist protocol was used or GnRH antagonist protocol was used. We'll ask about the trigger also, that HCG trigger was used or GnRH agonist trigger was used, because OHSS is significantly lower in GnRH agonist trigger. We'll ask about the follicle on final monitoring scan. We'll ask about the number of eggs collected, whether the woman has embryo transfer and how many embryos were replaced. We'll ask about the PCOM morphology on ultrasound scan or PCOS. What is difference between morphology? Morphology only tells about the USG scan, while in syndrome 2 out of 3 things should be there. First is oligoanovulation. Second is hyperandrogenesis, that can be clinical or biochemical. Third is PCOM morphology on ultrasound USG. Okay. Now symptoms, again, I am talking about symptom: abdominal bloating, discomfort and pain, and there will need for analgesia, nausea, vomiting, breathlessness, inability to lie flat or talk in full sentence, reduced urine output, leg swelling, vulvar swelling. See, with this picture mnemonic, you will remember the symptom. See, she's all swelling is there: leg swelling, vulvar swelling. Another thing is, see, I have made a toilet. This is so oliguria. She's saying, bring me the painkiller. Means she's having pain. See, her hands are on her abdomen. So discomfort is there and bloating is there. Bloating in the abdomen is there. She's unable to lie flat and she's shouting that I'm unable to lie flat. So basically, dyspnea is there. Okay, breathlessness is there. Dyspnea, breathlessness is there. Okay. Examination and investigation for suspected OHSS. General examination will have to assess for dehydration, edema, either pedal, pretibial, vulvar, or sacral. How to assess dehydration? First of all, how, if patient will come to us, how will we assess dehydration? We'll see the skin turgor. Okay, we'll pinch the skin on the back of the hand and sternum, and slow return suggests dehydration. Second, we'll see the mucous membrane, dry mouth, lip indicate dehydration. Okay, third, we'll see the capillary refill. How will we see the capillary refill? We'll press a finger tail, delay 2 seconds. Okay, if the capillary refill is taking more than 2 seconds, this suggests dehydration. Then we'll see for the eyes, if there is sunken eyes, that can indicate dehydration. We'll see the urine output. Low or dark colored urine will suggest dehydration. Now, we'll see edema. How we will assess edema? We'll press the bony areas to assess the edema. Okay, where tibia, shin of the tibia, ankle, and sacrum for 5 seconds. And we'll see for indentation. If there is indentation, that means edema is present, because we in OHSS there will be pitting edema. There are two types of edema, no? Pitting and non-pitting. In pitting edema, indentation will occur in OHSS. And second, another thing we'll see is, so we'll look for swelling location also, where like we'll look for pedal swelling location. We'll look for sacral swelling location or vulval. And we look for sudden weight gain also. Even sudden weight gain indicate edema. Then we'll check heart rate, respiratory rate, blood pressure, body weight, and temperature. We'll look for if there is muffled heart sound. This may suggest pericardial effusion. Abdominal, we'll look for ascites, palpable mass, peritonism, and we can measure girth of the abdomen. And for respiratory, we'll look for if there is a pulmonary pleural effusion or pneumonia or pulmonary edema. What is the key finding in pleural effusion? There will be stony dullness, dull percussion will be there, okay? And there will be decreased breath sound. There will be reduced tactile fremitus. What is meant by tactile fremitus? This means there will be less vibration felt on palpation due to fluid blocking the sound transmission, okay? Fluid in the pleural spaces absorbs sounds, making percussion dull and reduce sound transmission, because there is fluid in the pleural space. All this is happening because there is fluid in the pleural space. Now, pneumonia, bronchial breath sounds will be there. Dull percussion, that was in pleural effusion, there was stony dull percussion. In pneumonia, there is dull percussion. There is increased fremitus. Here it was decreased fremitus. Here it is increased fremitus, means stronger vibration felt on palpation as dense lung tissue conducts the sound better. Because in pneumonia, there is dense tissue. Okay, so it will conduct the sound better. So there will be increased fremitus. and there may be crackles, there may be wheezes, crackles due to fluid in the alveoli and wheezes due to airway narrowing. Okay. So why all this is happening? Because in pneumonia, there will be infection. Okay. Because of that, there will be increase in lung density. So there will be increased sound transmission, but there will be reduced air movement. In pulmonary edema, what will happen? There will be bilateral basal crackles. Basal crackles means there will be fluid in the lung bases causing abnormal sounds. Okay. Pulmonary edema. There will be dyspnea. There will be orthopnea. There will be orthopnea means difficulty in breathing when lying flat. There will be pink, frothy sputum, that is fluid mixed with blood from pulmonary congestion. There will be jugular vein distension due to fluid overload. There will be peripheral edema and swelling in legs, feet due to fluid retention. So, in pulmonary edema, fluid buildup in lung causes crackles, breathing difficulty, and fluid overload, and symptoms like JVD and peripheral edema. Okay. Now we'll talk about investigations. What investigations we'll do full blood count. We'll do hematocrit as a reflection of hemoconcentration. Hematocrit greater than 45 will indicate hemoconcentration. We'll do C-reactive protein. Okay, it tells about the severity. We'll do urea and electrolyte, particularly to assess the hyponatremia and hyperkalemia. We have already talked that it causes hypovolemia and hyponatremia. So to look for that, we'll do urea and electrolyte. We'll look for sodium to rule out hyponatremia, that is less than 135 millimole per liter of sodium. We'll look for potassium to rule out hyperkalemia, that is more than 5 millimole per liter. We'll look for serum osmolarity. Serum osmolarity, okay. Then we'll look for liver function test to assess for elevated enzyme, reduced albumin. Then we'll look for HCG. Serum albumin will look hypoalbuminemia is 35 gram per liter is hypoalbuminemia less than 35 gram per liter. It can occur in with OHSS and may be the marker for worsening of OHSS. HCG, we look for HCG to determine the outcome of the treatment cycle if appropriate. We look for ultrasound scan. We'll see the ovarian size and we'll see the pelvic and abdomen size, and we'll see the free fluid in the cavity. Free fluid in the pelvic and abdominal cavity. Other tests that may be indicated is if we suspect pleural effusion, pulmonary edema, or pericardial effusion, then we'll look for arterial blood gas D-dimer. We'll look for electrocardiogram, ECG, and echocardiogram. We'll look for chest X-ray. CTPA means computerized tomography, pulmonary angiogram, or ventilation per perfusion scan. V by Q scan will look for. If ovarian torsion is suspected, we'll do the clinical assessment of torsion, and we'll consider doing pelvic ultrasound or MRI. For non-gynecological symptoms such as headache, unilateral neck pain, okay, if there is headache and unilateral neck pain, then we should be alert because it may be internal jugular vein thrombosis, because thrombosis also is a complication of OHSS. So if there is headache and unilateral neck pain, there may be internal jugular thrombosis. Then we'll talk about the classification of OHSS. Okay. Now, classification of OHSS, it can be classified according to ASRM into 4 classification. First is mild. Mild is like abdominal distension and discomfort. See, this lady has hands here, she's having abdominal discomfort. Okay. Second is nausea, vomiting. See this nausea, vomiting. Okay. This is to remember from mild dyspnea. She's wearing this, but she has done one hole in it. This is a picture mnemonic. That means she's having dyspnea, mild dyspnea. Then increase ovarian size. Can you see her ovaries is increased ovarian size. Okay. Then diarrhea. She's in the toilet. So diarrhea. Mild is this. Moderate is mild stage features plus ultrasound evidence of ascites plus ultrasound evidence of ascites. And in blood alteration, hemoconcentration will be more than 41 and elevated WBC is more than 15,000 per ml. Now, how will we remember this? For moderate, how will we remember? See, moderate I'm talking about. See this, there is a picture mnemonic 41. There is a pack system to remember number, pack system. Okay, so 41, 4 is door, 1 is sun. So basically I remember 41 number with dawn. Can you see the dawn? Okay. And for 15,000 WBCs, 15,000 WBCs, I'll remember 15 by 15th August, our Independent Day. Okay. So now see, now there is a picture mnemonic that model means moderate. Model represent moderate with ascites in ultrasound at dawn. See, she's having ascites. We can see in the ultrasound that she's having ascites and she's hosting Indian flag at dawn. So see, moderate for model for moderate. Okay, this moderate is having ascites. Can you look in the to the ascites? She's having ascites that she's seeing in ultrasound. Means there should be there should be ultrasound in the ascites. Okay. Second, we talked about she's hosting a flag. That means WBC is 15th August. I told no. That means WBC is 15,000. Third is about hematocrit. Hematocrit concentration is 40, more than 41 in moderate. Okay. So this we remember by dawn. See, dawn. There is dawn. No, 4 means door, 1 means sun. So this equals dawn. Severe. See, in severe, there is mild plus moderate feature plus. In moderate, there was ultrasound evidence of ascites. Ultrasound, as we can see by picture mnemonic also, there was ultrasound evidence of ascites. In severe, there is clinical evidence of ascites. Clinically, we can see that ascites is present. Okay, there is hydrothorax. There is severe dyspnea. There is oligoanuria. There is intractable nausea, vomiting. See, this picture mnemonic, you can see 55 number. I usually remember by 2 people clapping. Okay, because 5 plus 5, 55. And 25 December is Christmas Day. So I remember with this cap, 25. So basically hematocrit and this WBCs we can remember by this. See, this picture mnemonic for severe is, can you see this pressure is increased means central venous pressure is low. This pressure is low. Okay, central venous pressure is low. From the picture mnemonic you can see. Syncope, can you see syncope? So see, syncope, for syncope I have made this. Okay, means they fainted, so they are looking like all white. For pressure, central venous pressure I have already told. Then weight, rapid weight gain, 1 kg. Can you see the weighing machine in the picture mnemonic? Weighing machine is there in the picture mnemonic to remember. Then ascites, clinically we can see it is ascites. Okay. Now this man cannot breathe. dyspnea is there, hydrothorax is there. Okay, so he's in a desert. That means there is oligouria and anuria. Can you see he's in a desert? And with this all, that man, can you see here? One man is clapping with both hands wearing Christmas dress. Means WBCs will be clapping. Clapping, we remember clapping for 55. So hematocrit will be more than 55 here. And Christmas dress means 25,000. WBCs will be 25,000. This picture mnemonic, if you can remember the symptoms and all. Sodium hyponatremia will be there, hyperkalemia will be there, creatinine greater than 1.6 milligram per deciliter, creatinine clearance less than 50 ml per minute will be there. Now for critical, we'll see critical now now anuria, there is no urine coming. In severe we saw oliguria and anuria. Here also there is anuria and there is everything will fail in critical. Okay, so there will be renal failure. Okay, in cardiac, there is arrhythmia and there is thromboembolism. There is clots everywhere. Then there is pericardial effusion. There is massive hydrothorax. In severe, we saw hydrothorax. Here, there is pericardial effusion and massive hydrothorax. Okay. And there will be ARDS, acute respiratory distress syndrome, and worsening of the severe findings. Blood alteration, there will be worsening of the severe finding. Now we'll we'll see the classification according to the Golan et al. This was adopted by Asrm. Okay, so grade 1, there is abdominal discomfort and distension. First is पहले पेट भरना चाहिए ना, इसलिए पेट पहले भरना चाहिए क्या आदमी की, जस्ट फॉर निमोनिक. ओके, फर्स्ट रिक्वायरमेंट इज हमारा पेट भरना चाहिए. तो ग्रेड 1 इज abdominal distension and discomfort. Grade 1 plus nausea, vomiting and diarrhea and ovaries enlargement 5 to 12. So second thing, if पेट भर गया तो उसके बाद क्या होगा, पेट में गड़बड़ी स्टार्ट हो जाएंगी. सेकंड में क्या हो जाएगा, पेट में गड़बड़ी स्टार्ट हो जाएंगी. दैट मीन्स नॉजिया होगा, वॉमिटिंग एंड डायरिया होगा एंड ओवरी इनलार्ज हो जाएगी 5 to 12 centimeter. Moderate, what will happen in moderate? As we have already discussed, in moderate ultrasound evidence of in Asrm classification also, there in moderate there was ultrasound evidence of ascites. In here Golan classification also there will be ultrasound evidence of ascites. Okay, that means greater than 50 ml in pouch of Douglas, adenoids and abdomen. There will be greater than 50 ml fluid in these cavities. Then severe. Now here severe is somewhat different, but as we have seen in the Asrm classification also, in severe there will be clinical evidence of ascites, there will be hydrothorax, there will be breathing difficulty, have at least, so there will be both in abdomen also and in thorax also there will be fluid. Okay, as we have already discussed in Asrm classification. Can you see clinical, like it is clinics, that means clinical evidence will be there. In severe there will be clinical evidence and everywhere there is water. Can you see, everywhere there is water. So and there is door we remember by 4 door. So in Golan classification, grade 4 is severe and everywhere water, means even in lungs and even in abdomen there is all water, hydrothorax and ascites is there. So we'll remember Golan severe from this picture mnemonic. How will we remember grade 5? See, 5 look like a hook. 5 look like a hook. So we'll see this hook is holding some vessels which has blood. Okay, so we'll see blood, volume and viscosity. Now viscosity may raise, that causes thromboembolic event. Okay, now can you see the knee has injured. Knee means kidney. Knee has injured means kidney perfusion. There will be diminished kidney perfusion and function. So grade 5 severe also we have done. Now we'll do grade 6 critical. What will happen in grade 6? There will be respiratory distress syndrome. There will be, here we see diminished perfusion. Here we saw diminished perfusion and function. Here there will be, everything will be shut. So there will be respiratory distress syndrome, renal failure. Third is venous thromboembolism will occur. In severe, we were seeing that there were clot, there was more viscosity, but in there were no any thromboembolism was not there, but in critical there will be venous thromboembolism. Okay. Fourth is tense ascites will be there, hydrothorax, tense ascites, hydrothorax plus pericardial effusion. Now even heart has water in it, means pericardial effusion, and there is will be variable enlarged ovary, there will be variable hemoconcentration. All the things which was happening in the this ASRM severe cases will happen in the Golan critical case. Okay. All this will happen in the Golan critical case, means hemoconcentration more than 55, WBCs more than 25,000, and creatinine more than equals to 1.6 milligram per deciliter, and creatinine clearance less than 50 ml per minute. Now management of OHSS. Now we'll see how will we manage OHSS. See, first, during the initial assessment, modalities like telephone or face-to-face consultations are used to clarify the diagnosis. Key features include abdominal pain, shortness of breath, and reduced urine output. Okay. Then immediate attention is required if severe symptoms such as respiratory, renal, or ovarian impairment. See, now we'll see severity classification, like which is determined by the signs of worsening. These include increased abdominal distension and pain. There will be more pain, there will be more abdominal distension. And second is shortness of breath. Third is tachycardia or hypotension. Fourth is reduced urine output. Reduced urine output means less than 1000 ml per 24 hours. Or fifth is there will be positive fluid balance. What does positive fluid balance means? That where fluid intake via oral or IV fluid exceed the fluid output by greater than 1000 ml per 24 hours, means we are taking fluid. Suppose we take 3000 fluid and only 1000 we are producing urine, then positive fluid balance in 2000. Okay, so there shouldn't be more than 1000 ml per 24 hour positive fluid balance. Okay. Other signs include weight gain, increased abdominal girth, and rising hematocrit exceeding 45, sorry. Outpatient management. How will we do outpatient management? In outpatient management, mild OHSS cases are managed outside the hospital. Okay. Patients are advised to ensure adequate fluid intake, typically at least 1 liter daily, guided by thrust. Okay. So this helps maintain the hydration and support recovery. In outpatient management, the pain relief is prioritized by avoiding NSAID. We won't use NSAIDs in this, okay? Due to the risk of renal impairment. Renal impairment can happen. That's why we won't use NSAIDs. What we'll use is paracetamol or oral opioids. Okay? For effective case control, paracetamol and oral opioids are recommended. Fluid balance is also very critical and must be monitored until there should be input and output chart. If urine output, I have already told, if urine output is less than 1000 ml per 24 hour, or if their positive balance is more than 1000 ml per 24 hour, further evaluation and management are necessary to prevent complication. Now we'll see about the indication of hospitalization. When considering indication of hospitalization, key criteria include unsatisfactory pain control. Pain control is unsatisfactory. Second is inability to maintain adequate fluid intake because there is nausea and vomiting. So there is worsening symptoms despite outpatient management. Worsening OHS despite outpatient management. Fourth is critical complications such as thrombosis, ARDS, thrombosis, this is clotting, okay? ARDS, acute respiratory distress syndrome, then renal failure. Additionally, hospitalization is necessary if patient cannot attend regular follow-ups, okay? Now, hospital management. Within hospital, how will we manage? Severe OHSS require thromboprophylaxis to decrease the risk of thromboembolism. Fluid management is carefully controlled to avoid excessive IV fluid, which can worsen ascites. Okay. Now, crystalloid and colloid may be used. Crystalloid or colloid may be used judiciously to address dehydration and hemoconcentration. Now, colloid therapy, what we'll use in the colloid therapy? We can use albumin 25% or hydroxyethyl starch, okay, that can maintain the plasma volume. But it is important to note that HES has been banned or withdrawn in UK. Because of more mortality. Now, parasynthesis may be used to relieve the tense ascites and also to improve the oliguria. While diuretic are selectively used to manage persistent oliguria when fluid balance has been addressed, okay? Only in persistent oliguria despite adequate fluid replacement. Why diuretic should not be used when the cause of low urine output isn't due to unrelieved ascites? The fluid balance has already been addressed. If there is ascites, first we'll have to relieve that ascites. Because of that, there may be oliguria. First, relieve this ascites. We don't have to use injudiciously. Diuretic should be used very carefully. Now, severe cases. See, for severe cases, advanced invasive hemodynamic monitoring is often required, particularly when dehydration or hemoconcentration persist despite fluid replacement. Okay. Now, invasive hemodynamic monitoring means it refers to continuous measurement of cardiovascular parameter using specialized medical device that are inserted into the body, like CVP monitoring. What will insert? There may be arterial line, pulmonary artery catheter. So this type of monitoring is crucial in critical ill patients such as that of severe OHSS, where fluid status, blood circulation, and organ perfusion may be carefully assessed and managed. Okay. Now, why is invasive hemodynamic monitoring needed? Invasive hemodynamic monitoring needed. See, in severe OHSS, patient can develop fluid shift leading to dehydration and hemoconcentration. Fluid shift, okay, leading to dehydration and hemoconcentration. So due to thickened blood, excessive fluid movement into the third space like abdomen can occur. There may be respiratory distress or renal impairment, okay, due to excessive fluid accumulation, and there may be circulatory collapse in extreme cases. Okay, so to manage these complications, doctor use invasive hemodynamic monitoring to track fluid balance. Why we use invasive hemodynamic monitoring? To track fluid balance, blood pressure, organ function in real time, allowing for precise treatment and adjustment. Okay. Now we'll talk about critical OHS. Critical OHS may require intensive care to manage the complication like thromboembolism, acute respiratory distress syndrome, and renal failure. Okay, so there we can also use dopamine infusion and oral docarpamine, or oral docarpamine is dopamine prodrug. Dopamine product drug. Why are we using this? Because these both drugs work by stimulating dopamine receptor in kidney, leading to vasodilation in renal artery. This increases the blood flow to the kidney, improving the urine output and helping to prevent fluid overload and renal failure in severe OHS cases with oliguria or low urine output, means low urine output. Now we'll see monitoring and assessment of inpatient in OHSS. Objective of inpatient monitoring of people with OHSS to monitor changes in severity of the disease process and to identify any complication at early stage. To look for severity and complication, we'll have to monitor. Inpatient means who are not hospital admitted. So inpatient monitoring of OHSS include daily recording of body weight, abdominal girth, fluid balance, full body count, noting the hematocrit, serum electrolyte, liver function test, and clotting. Depending on the clinical features, we can also monitor arterial blood gas, ECG, chest X-ray, and other imaging such as chest ultrasound may be required. Sign of worsening OHSS include increased abdominal girth, weight gain, oliguria with positive fluid balance, and elevated increase in hematocrit. See, how will we know that recovery is happening? First symptom is diuresis. Second is normalization of hematocrit. Third is normalization of electrolyte and osmolarity. Fourth is reduction in abdominal girth and reduction in body weight. C-reactive protein level have been shown to correlate with other biomarker like C-reactive protein has been shown to correlate with other biomarker of OHSS, such as abdominal girth, weight, and may have a role in monitoring severity. This is given in RCOG. This all we are talking about RCOG 2024, the review draft. Okay. Now we'll talk about prevention of OHSS. See, understanding the prevention of and management of OHSS, we'll have to look into some points. Basically, 3 points: primary prevention, secondary prevention, and tertiary prevention. Okay. So OHSS is a potential complication of fertility treatment, particularly IVF, where excess ovarian stimulation led to the leakage of the fluid into the abdominal cavity, and other complications may occur. So to minimize the risk of OHSS, various prevention strategies have been developed. I've already said that these are primary prevention, secondary prevention, and tertiary prevention. Each of these strategies target different stages of treatment and patient risk factors. Okay, so we'll talk about the primary prevention first. In primary prevention, we'll talk about the GnRH antagonist protocol. Okay. So the GnRH antagonist protocol is commonly used method of primary prevention of OHSS. This protocol works by lowering circulating estrogen level. Okay. And which helps reduce chances of OHSS. It is essentially beneficial for high risk patient, including that who has been diagnosed with PCOS and who has been diagnosed with PCOM, as well as those classified as high responder. High responders means patient whose ovary react strongly to the stimulation medication. Okay, there was a Cochrane review of 29 randomized RCTs, so randomized control trials. So it has provided strong evidence that GnRH antagonist protocol significantly reduces the risk of OHSS compared to other methods. Okay, importantly, when compared to GnRH agonist protocol, this approach has been shown to result in lowering incident of OHSS while maintaining the similar birth rate. Live birth rate was similar to GnRH agonist protocol, but risk of OHSS was very low. This means that the patient can achieve successful pregnancy outcome while reducing the risk of developing OHSS. Okay. So based on this evidence, fertility especially strongly recommend to use GnRH antagonist protocol for prevention of OHSS in high risk of having OHSS. Now we'll talk about the GnRH agonist trigger, that is secondary prevention. In addition to the primary prevention, strategies like GnRH antagonist protocol, there are further measures that reduces the risk of OHSS, especially for the patient who are high risk. Okay, so this brings us to the secondary prevention, which focuses mainly on modifying final stage of ovarian stimulation. Okay, that is triggering stage, to prevent excessive hormonal response. So we'll talk about GnRH agonist trigger here. See, in standard IVF protocol, HCG is often used as trigger for final oocyte maturation before egg retrieval. However, HCG has been linked to increase in the OHSS risk because it has prolonged half-life and can lead to excessive luteal phase stimulation. So to counteract this, GnRH agonist trigger is used instead of HCG, which allow for the final maturation while reducing the risk of OHSS. So this approach is particularly useful for high risk group, including PCOS. It is even used in oocyte donor because we don't have to use fresh cycle in oocyte donor. So it is, and there will be decreased risk of OHSS in oocyte donor also. So we use GnRH agonist trigger in PCOS patient, PCOM patient, any high risk patient, and oocyte donor. Patient who receive GnRH agonist trigger have significantly lower OHSS rate than who receive HCG trigger. So this make it a GnRH agonist trigger as highly effective alternative to prevent OHSS risk in high risk patient. Okay, means instead of HCG, now we'll use GnRH agonist trigger. However, when we use GnRH agonist trigger, some concerns are there, okay? Because it may lead to decreased live birth rate in fresh autologous cycle. Why? Because fresh autologous cycle means when patient's own embryo are transferred immediately. Why? Because there is insufficient luteal phase support. Following this trigger, after we use GnRH agonist trigger, there won't be enough support, luteal phase support. There will be early luteolysis, okay? So, but this issue can be managed with proper adjustment in luteal phase supplementation, ensuring that pregnancy outcome remain optimal. Okay. For this reason, it is recommended that high risk patient uses GnRH agonist trigger, but with intensive luteal phase support. This will allow patient to avoid OHSS while maintaining favorable pregnancy rate. Making GnRH agonist as a crucial strategy for secondary prevention in fertility treatment. Now we'll talk about, now we have diverted from the topic. Now we'll be talking about the GnRH, what we do in GnRH when we use GnRH agonist trigger. Slightly we are diverting from the topic. First, we'll give intensive luteal phase support. See the importance of intensive luteal phase support. What is luteal phase? Luteal phase is the period following ovulation where body must maintain adequate level of progesterone and estradiol to support implantation and pregnancy, early pregnancy. After using GnRH agonist trigger as a trigger, the natural luteal hormone support from the ovaries often insufficient, increasing the risk of implantation failure and pregnancy loss. To prevent this, intensive luteal phase support is necessary. So one very well-known intensive luteal phase support protocol is Ingman protocol, which include IM progesterone starting with 50 milligram daily. See here, we can see in the diagram. This is good diagram. IM progesterone, we are starting with 50 milligram IM daily, which is increased to, this can be increased to 75 milligram if progesterone level drops below 20 nanogram per liter. This is Ingman protocol. Okay. Now we'll use, and other thing what we'll use is estradiol patches. Patient apply 3 estradiol patches of 0.1 milligram every other day. Increasing to 4 patches, or adding oral estradiol daily if estradiol level falls to less than 200 picogram per ml. This will continue till 10 weeks to ensure adequate hormone support. So basically it is requiring See, we'll have to monitor E2 and progesterone here. Hormone level should be regularly monitored at day 3, day 7, and weekly up to 10 weeks. The target value for successful implantation and pregnancy maintenance are progesterone level should be above 20 nanogram per ml and estradiol level should be above 200 picogram per ml. This protocol led to pregnancy rate of approximately 53%, which was comparable to 48.3% pregnancy rate, which was achieved by HCG trigger. This confirmed that intensive luteal phase support can effectively maintain pregnancy and decrease OHSS risk. Now, this was about Ingman PET protocol, okay? Now, alternative luteal phase protocol is Imber et al. In this, intramuscular progesterone 50 milligram daily and oral estradiol 6 milligram daily is used until 10 weeks. This method is viable alternative while requiring less intensive monitoring of hormone. However, close monitoring is still essential as some patient may need adjustment of hormone dosage. And if intramuscular progesterone is not available, vaginal progesterone can be used as substitute, but intramuscular and intensive phase is necessary. Now we'll talk about adjuvant low dose. Again, we are talking about, this was the first intensive. Again, if we are using GnRH agonist trigger, we can use adjuvant to support the luteal phase. We can use adjuvant low dose HCG protocols. So basically, in addition to intensive luteal phase support, some protocol incorporate low dose HCG as an adjuvant to improve pregnancy outcome while still minimizing the risk of OHSS. These strategy aim to provide additional support, luteal support, without causing excessive ovarian stimulation. Okay. Now, several protocol has been developed that utilizes small dose of HCG to support the luteal phase without significant increase in OHSS risk. This include first is dual trigger protocol. This method uses, we can see here, this method uses both GnRH agonist trigger plus low dose HCG. Low dose of HCG, that is 1000 to 2500 simultaneously. We see dual SIM, no? Like that only, dual protocol. At one time, we can use both the same. Like that only, that is dual protocol. Okay, we use dual protocol. Now, the goal of this is to provide extra luteinizing support for this dual protocol. We are using, can you see, both GnRH agonist trigger and HCG simultaneously. So the goal is to have extra luteal support leading to improved oocyte maturation and embryo quality, good embryo quality. While HCG increases the OSS risk at high dose, low dose reduces the risk while still supporting the luteal phase. It is particularly beneficial for patients with low peak estradiol level, that is less than 4,000 picogram per ml estradiol level, or those with history of luteal phase dysfunction. Now we'll talk about second adjuvant HCG protocol. First was dual trigger. As we can see here, dual trigger is used with intensive luteal phase support. Now we talk about the adjuvant HCG given on the retrieval day, oocyte retrieval day. This was first and this is second. Okay, so a single bolus of 1500 HCG is administered within 1 hour of oocyte retrieval alongside standardized luteal phase support. See, in dual trigger, we were talking about intensive luteal phase support. Here, with 1500 HCG given within 1 hour after oocyte retrieval, we have used standard luteal phase support. So, standard regimen means what? Intensive luteal phase support is an aggressive treatment. But in standard luteal phase support, this includes vaginal micronized progesterone, at a dose of 200 milligram 3 times daily. Additionally, we can incorporate oral estradiol supplementation with dose reaching up to 6 milligram per day. This is standard protocol. Okay, this is not intensive protocol. So with 1500 HCG within 1 hour of oocyte retrieval, we can use standard dose protocol. GnRH Agonist Trigger with HCG, which was given within 1 hour, 1500 HCG was compared with HCG trigger alone. So this shows that pregnancy rate were comparable, but there was slightly higher risk with this protocol, like 9 points, slightly higher risk of OHSS with this protocol. So this protocol is used with caution in high responder, means if there is E2 level more than 4,000 picogram per ml, we won't use this protocol. Okay. Now third is, this was second. Now third is adjuvant HCG 2 days post OP, means in this protocol 1500 international unit HCG bolus is given 48 hours after oocyte retrieval. After oocyte retrieval, but without additional progesterone supplementation. Progesterone supplementation was not given. Studies showed that pregnancy and live birth rate are comparable to HCG trigger protocol with no cases of OHSS. Okay, so while this approach is promising, further large-scale studies are required to confirm the effectiveness. Fourth is very low dose HCG. In this method, 125 international unit of recombinant HCG is administered daily, starting from day 2 or day 6 of stimulation and continued throughout the luteal phase. it has been found to increase the luteal progesterone level and produce comparable pregnancy to standard luteal support. However, it is not commercially available. 125 international recommended HCG is not commercially available in many countries, and further research is needed. Further research is needed before it can be widely recommended. So while low dose HCG strategies provide an additional option for luteal phase support, they should be used carefully. Particularly in the patient with high risk of OHSS, it is important to monitor hormone level closely and adjust the protocol based on the individual patient response. Okay. Now we'll talk about protocol for recombinant. These all I'm using. This is BC. When we use GnRH agonist protocol, what all we use, we are seeing this. Okay. It is basically somewhat deviation from our topic. So we use recombinant LH, luteal, because GnRH agonist is used to decrease OHSS. What else we'll do while using GnRH agonist protocol? That we'll see. Luteal GnRH agonist, luteal coasting and cycle segmentation. Okay. Now see recombinant LH. Recombinant LH, in addition to intensive luteal phase support and adjuvant low dose HCG protocol, these all are also used. What all are used? A recombinant LH, luteal GnRH agonist, luteal coasting, cycle segmentation. Each of these methods is designed to optimize hormone support while minimizing the risk of OHSS and any other complications. So now we'll talk about the recombinant LH for luteal phase support. See, this is an alternative to HCG for luteal phase support. So unlike HCG, which has long T half and can increase the risk of OHSS, recombinant LH has shorter T half, making it a safer option for high-risk patient. Okay. 6 doses of 300 recommended given on alternative plus standard luteal phase support. Can you see? This diagram shows. So clinical studies suggest that using recombinant LH for luteal phase support result in the similar pregnancy compared to HCG trigger. No OHSS case was found who received recombinant LH for luteal support. However, since dose and timing are not standardized and it is very expensive, so further research is needed before this method becomes routinely clinical practice, and it's very expensive, so it's not a practical way to give this. Okay, so it is difficult to give this. Now another is luteal GnRH agonist administration. See, we can see from the diagram. See, another alternative approach is the use of GnRH agonist trigger during GnRH agonist during, not trigger, agonist during luteal phase. This method involves administration repeated dose of GnRH agonist. Can you see 100 microgram nasal buserelin 3 times a day? So we'll give repeated dose. In Gardner, it is talked about the triptorelin 0.1 milligram every other day. Next day, we won't give anything. Then next day, again, triptorelin 0.1 milligram with progesterone in oil starting on embryo transfer day. This will stimulate LH surge to support corpus luteum. Thereby significantly reducing, this will cause effective luteal phase support without the use of HCG. Thereby, this will significantly reduce OHSS risk. Research comparing luteal GnRH agonist administration to HCG trigger has shown no significant difference in implantation rate, clinical pregnancy rate, and ongoing pregnancy rate, but there is lower risk of OHSS. However, one limitation of this approach is that serum LH level are not routinely monitored, which may make it difficult to determine the optimal dosing regimen. Now we'll talk about the luteal coasting. This all are used with GnRH agonist trigger. Okay, luteal coasting is a method in which no additional steroid hormone like progesterone or estradiol are administered unless serum progesterone level drop below the supplementation below a critical threshold. Okay, unless progesterone drop below a critical threshold. This approach aims to minimize the risk of excessive hormone stimulation. Okay, so in case where serum progesterone level falls below 15 nanogram per ml, a single bolus of 1500 IU HCG may be given to maintain the adequate luteal support. While these methods help reduce unnecessary hormone exposure, it needs frequent monitoring as progesterone level can fluctuate rapidly within minutes. Okay, so it needs frequent monitoring. See it. With the help of diagram, we can see when progesterone level were below some critical value, we added HCG IUI in the luteal phase. Okay, this is called luteal coasting, but it needs frequent monitoring. So it is very hectic monitoring. Now we'll talk about cycle segmentation and freeze-all strategy for patient at very high risk of OHSS. Cycle segmentation is often the best strategy. In this approach, what happens is a freeze-all policy is applied or adopted. Freeze-all policy is adopted where all embryos are cryopreserved or frozen for transfer in later cycle, rather than performing a fresh embryo transfer. Fresh embryo transfer is not performed. So the main advantage of this method is that it completely eliminates the risk of late onset OHSS, which is triggered by rising HCG level in early pregnancy. This method is particularly beneficial for PCOS patients, as studies have shown that the patient who has previously had cycle cancellation due to high risk of OHSS achieve a 33% of pregnancy rate when they underwent a freeze-all cycle and later embryo transfer. Another study, this was one study, another study by Garcia Velasco found that high-risk OHSS patient who underwent freeze-all approach had 50% clinical pregnancy rate compared to only 29.5% in those who proceeded with fresh transfer. This is freeze-all. These findings demonstrate that cycle segmentation can improve the pregnancy rate while preventing OHSS complication. So choosing the right luteal phase support strategy. So the decision on which luteal phase support approach is used depend on the multiple patient specific factor, including serum estradiol level, follicular count, prior response to ovarian stimulation. By tailoring the luteal phase support to each patient individual needs, fertility specialists can optimize pregnancy success while minimizing the OHSS risk. See, we'll talk about individualized luteal phase management. We'll talk about personalized approach. Different patient require different level of hormonal support depending on their estradiol level and follicular count at the time of trigger. Based on this parameter, fertility specialists will determine whether additional support or modification is required or not. Now we'll talk about for patient with serum estradiol level less than 4,000 picogram per ml. This much estradiol can safely undergo GnRH agonist trigger, but they may benefit with small dose of HCG. As we have already discussed that in dual trigger, we have discussed when there is less than 4,000 picogram estradiol, we can use dual trigger, okay? So HCG plus GnRH agonist trigger we are using for additional support. The combination of these is called dual trigger. We can see here. This HCG dose helps rescue the corpus luteum, ensuring a adequate progesterone production while keeping OHSS minimum. Progesterone is okay. Progesterone is good, optimal, while keeping OHSS risk low. And what else we'll use with this? We'll use intensive luteal phase support with progesterone and estradiol supplementation. This approach is particularly useful with who have experienced poor luteal support in previous cycle. Now we'll talk about the patient with serum estradiol level more than equals to 4,000 picogram per ml. For patient with high estradiol level, GnRH agonist trigger is usually used alone. This is sufficient to maintain adequate luteal function. We'll use GnRH agonist with intensive luteal phase support. Now we'll talk about the follicular monitoring. We'll talk, as we already know that follicular count is a predictor for OHSS risk. So in addition to the estradiol level, the number of follicle on the trigger day plays a significant role in determining the best luteal phase support strategy. So for the patient with fewer than 25 follicle, greater than 11 millimeter, or in some study less than 18 fewer than 18 follicle, 10 to 14 mm. These two studies were there. One shows less than 25 follicle, another less than 18 follicle. So basically, patient with moderate follicular count can safely undergo GnRH agonist trigger with a small dose of HCG at the time of oocyte retrieval. At the time of oocyte retrieval. Plus intensive luteal phase support. Now we'll talk about the patient with more than 25 follicle greater than 11 millimeter or greater than 18 follicle greater than 10 to 14 millimeter. These patients are very high risk of OHSS, making it unsafe to use any form of HCG, even in low dose. In such cases, best strategy is GnRH Agonist trigger combined with freeze all approach. By freezing all embryos and delaying embryo transfer, OHS's risk is almost completely avoided, and embryo transfer can then be performed in later cycle when hormone levels are normalized. Now we'll talk about the, okay, these I have already explained. Now we'll talk about the genetic predisposition. See, in interestingly, in some patient developing OHSS even after GnRH agonist trigger. So certain recent study have suggested that certain genetic variation in FSH, GnRH, genetic variation in GnRH, FSH, LH receptor gene and VGF pathway may make individual more susceptible to OHSS despite using preventive measures. These findings suggest that genetic testing may help identify the patient at high risk of OHSS and allowing for even more personalized treatment protocol. For such patients, alternative stimulation strategies such as in vitro maturation or Letro's co-treatment may be required to further reduce the risk of OHSS. Now we'll talk about the tertiary prevention. Now we have come again in our topic, that is OHSS. That was we were talking about when we use GnRH agonist trigger, but all we'll have to use with it to risk because GnRH agonist trigger is mostly used to decrease the risk of OHSS. Now we'll talk about tertiary prevention. See, we'll understand in this tertiary prevention how additional treatments such as aspirin, metformin, dopamine receptor agonist, and albumin infusion can further prevent the OHSS complication. Even with the careful stimulation protocol, some patients may still develop OHSS. In such cases, tertiary prevention strategies are required to manage the symptoms and reduce complication and prevent conditions from worsening. These strategies involve the use of these drugs, okay, which I have talked, like aspirin, metformin, dopamine agonist, that is cabergoline, and albumin and calcium administration, which help to control the physiological changes associated with OHSS. One of the simplest pharmacological intervention is aspirin. How it works, aspirin? Reduces platelet activation and VGF activity. Since VGF is plays a key role in the increasing vascular permeability, that is a major factor in the OHS. It is thought that low dose aspirin, that is 100 milligram daily, may reduce the OHSS incidence. While aspirin may offer some benefit, it is not a standalone treatment and is generally used and as a adjuvant therapy in high risk patient. Okay. It also reduces release of vasoactive substance like histamine, serotonin, platelet-derived growth factor, and lysophosphatidic acids. We will talk about the metformin now. Metformin has been explored to reduce likelihood of OHSS. It decreases the intra-ovarian androgen level and the estradiol secretion, thereby modulating ovarian response to stimulation. However, studies suggest that it is most effective in PCOS patient, but in PCOM patient, it is not that effective, or in patient with normal weight individual, it is not that effective. relcovaptan. Okay, relcovaptan is vasopressin receptor antagonist. It blocks VGF induced vascular effect like capillary permeability, and experimental evidence shows reduced OHS marker in animal model. It is in experimental stage right now. Now tertiary prevention, we'll see tertiary prevention. Another is withholding gonadotropin, that is called coasting, and we'll talk about dopamine receptor agonist. Okay. See, even with careful ovarian stimulation, some patients develop a sign of OHSS requiring additional preventive measures. Some methods include withholding gonadotropin like coasting, which involves temporary stopping gonadotropin injection while continuing monitoring. Another approach is dopamine receptor agonist like cabergoline, which help regulate the vascular permeability and reduce the fluid accumulation. These strategies are particularly useful for high-risk patients who have developed excessive follicular growth and need control intervention to prevent severe OHSS. Okay. So first is with this withholding gonadotropin. So coasting is a strategy when a patient shows signs of excessive ovarian response, but before the administration of final trigger. Before final trigger for ovulation, the goal of this method is to allow estradiol level to drop to safer range before proceeding with accurate retrieval. In this approach, gonadotropin stimulation is completely stopped. But the patient continues to be monitored daily with a hormone blood test and ultrasound. So once the serum estradiol level decline to a safer level during coasting procedure, estradiol level should fall to 3000 picogram per ml before administering the final trigger injection. However, studies on coasting shows a mixed result. Some researchers indicate that coasting can be successfully reduce OHSS risk, while other studies shows no such difference. Okay. So additionally, like if you prolong coasting by more than 4 days, it has been linked with lower implantation rate, possibly due to effect in oocyte quality. Because this coasting is used cautiously and is not the first line approach unless there are clear indication of excessive ovarian response. Now we'll talk about the dopamine receptor agonist. This is the most effective way to control OHSS in this stage. Dopamine receptor agonist like cabergoline is used. How does this work? See, in OHSS, there is increased vascular permeability, meaning there is leak from blood vessel into the body tissue causing swelling and complication. This permeability is caused by VGF. So in cabergoline work by reducing VGF production, thereby decreasing the severity of OHSS. So in clinical studies, including RCTs and systemic reviews, have shown cabergoline significantly lower the risk of OHSS without affecting pregnancy rate. That means it is safe and effective options for high-risk patient. The standard dose is 0.5 milligram orally once daily for 7 to 8 days. Okay. When will we start? We'll start from the day of oocyte retrieval or HCG trigger. From the day of oocyte retrieval, cabergoline or HCG trigger. There are also alternative regimen like 0.25 milligram daily for 8 days. Daily for 8 days. Okay. Or extended use for 3 weeks. This is alternative regimen. When there is a severe case, then we can extend for 3 weeks. In most cases, cabergoline is well tolerated with only mild side effect like nausea, dizziness, stomach discomfort. Hence, it is strongly recommended for moderate to severe OHSS prevention in high risk cases. Now we'll talk about albumin and calcium administration. Another approach is albumin infusion. Albumin act as a plasma volume expander. Okay, albumin, meaning it helps retain fluid in the blood vessel and prevent them from leaking in the tissue. It also binds VGF related vasoactive substance. Binds with a VGF related vasoactive substance, which are responsible, these substances are responsible for vascular permeability in OHSS. While older studies suggest that albumin reduces OHSS risk, recent study including systemic review has shown no consistent benefit. In fact, some studies found that albumin may lower the pregnancy rate, and there is also a risk of allergic reaction and anaphylaxis. Due to these concerns, albumin is no longer recommended as a routine OHSS preventive strategy. The doses of albumin, we'll talk about doses of albumin is 25% in dose of 50 to 100 gram infused over 4 hours and repeated every 4 to 12 hours as needed. You can see the doses here. Now we'll talk about calcium. This inhibits renin secretion and reduces VGF production. So doses are IV calcium gluconate 10 ml of 10% solution in 200 ml saline, administered around the time of oocyte retrieval or thereafter. Calcium is shown to lower OHSS incidence and as effective as cabergoline in PCOS women. Recommendation is albumin is not recommended for routine OHSS prevention due to limited efficacy and risk. Calcium shows as an promising alternative. Now we'll talk about the cryopreservation freeze-all. We have already talked about the cryopreservation, in which patient will do cryopreservation. Okay, like more than 25 follicle or more than 18 follicle greater than 10 to 14 millimeter will do freeze-all. It prevent the late, we have already discussed that it prevent the late OHSS by by avoiding the endogenous HCG rise in fresh embryo transfer cycle. Residual risk, OHSS risk may persist even in freeze-all cycle, especially if there is an aggressive ovarian stimulation. Recommendation is cryopreservation is safe and effective option for high-risk patient, though it may not eliminate all the risk. Now we'll talk about in vitro maturation and letrozole. See, for some high-risk patient, an alternative method to conventional overstimulation is IVM. Instead of stimulating the ovary aggressively, in vitro oocyte are immature oocyte are collected early and matured in lab. This significantly reduces the risk of OHSS because ovaries are not exposed to the high hormonal level. Okay, so IVM is especially used for PCOS and PCOM patient who are naturally prone to OHSS. I have already had a lecture in IVM indications and all, so kindly see that. Another hormonal adjustment that has been studied is letrozole. So letrozole is a aromatase inhibitor that lowers the estrogen level and may reduce the OHSS risk. The usual dose ranges from 2.5 milligram to 7.5 milligram daily for 5 days after oocyte retrieval. Some studies suggest that higher dose 7.5 offer better protection against OHSS, while letrozole may not be as effective as cabergoline. It has shown better result than aspirin in reducing the early OHSS risk. Dose reduction in OHSS may be due to leutolytic effect rather than VGF modulation, because letrozole has a leutolytic effect. That's why it might help in OHSS. We will talk about luteal phase support and preventive adjustment. Now, luteal phase support means supporting implantation and early pregnancy. So basically, here it's given that vaginal progesterone is preferred over HCG due to lower OHSS risk. Okay, we'll have to avoid HCG. We don't have to give HCG. But previously, as you have seen, we read about HCG. We were giving HCG during luteal phase support, but that was, we were talking that time about when we give GnRH agonist trigger to the patients, okay, when we were giving GnRH agonist trigger. But now we are talking about the patient who have high risk of OHSS. In that group, we won't give HCG. We'll avoid giving HCG, okay. The patient in whom we have used GnRH agonist trigger, because nowadays they are being OHSS free clinic in which every patient is being given GnRH agonist trigger. So we can give HCG as a luteal phase support in those patients in which OHSS risk is not there. Okay, but if there is OHSS risk, and we have to avoid giving HCG. Now, Cochrane meta-analysis showed that HCG is not superior to progesterone and increase OHSS risk during luteal phase support. Okay, so it is saying that HCG is not superior to progesterone and it increases the risk of OHSS. Second is GnRH agonist trigger for luteal phase support. In some patient, we are using GnRH agonist trigger for luteal phase support. As we have seen above, that we were giving triptorelin in alternate 0.1 mg dose alternative a day. Previously, we have discussed, okay? So propose an alternative for high-risk patient while promising it does not completely eliminate the severe OHSS risk. Still, after even giving GnRH agonist during luteal phase support, there is risk for OHSS. So what is the recommendation? Avoid HCG for luteal phase support in women at high risk for OHSS. Use progesterone or GnRH agonist instead. We don't have to use HCG. We'll have to use either progesterone or GnRH agonist for luteal phase support. Now see here, this is from OHSS from Gardner I have taken. Here it is said that we'll use vaginal route is preferred. Vaginal progesterone we'll use in OHSS patient, okay? Vaginal progesterone. But in GnRH agonist chapter, it was shown that while using a GnRH agonist trigger, we'll have to use IM progesterone. If you are using HCG trigger, then okay, vaginal route is okay. Vaginal progesterone is okay. But when we are using GnRH agonist as a trigger, we'll have to use intensive phase support. And in that, IM progesterone is given. See, as the line says, In protocols utilizing an HCG trigger, studies suggest that there is no superiority of IM progesterone over vaginal progesterone. However, this may be essential after GnRH agonist trigger, means IM progesterone may be essential after giving GnRH agonist trigger. While in other cases, even vaginal progesterone can be given as luteal phase support. Now, Rcog 16. We'll discuss the question answers now. What is the role of parasynthesis in OHSS, or how should ascites and effusion be managed? See, what are the indication of parasynthesis? It includes, first is if there is severe abdominal distension is there and abdominal pain is there, okay? Distension and pain secondary to ascites. Because of ascites, secondary to ascites, there is distension and pain, abdominal pain. Second is shortness of breath, respiratory compromise secondary to ascites. Because of ascites, patient is unable to breathe and there is respiratory compromise and increased abdominal pressure. Third is oliguria despite adequate volume replacement. Even if we are giving adequate volume fluid, even then there is oliguria. And secondary to, why is this happening? Secondary to increase abdominal pressure causing reduced renal perfusion. Decreased renal perfusion. So parasynthesis should be carried out under ultrasound guidance. Okay, and can be performed abdominally or vaginally. Intravenous colloid therapy should be considered for women who have large volume of fluid replaced during parasynthesis. Monitoring is needed for the hospitalized OHSS patient. We'll have to do daily monitoring of weight, abdominal girth, fluid intake and output, fluid intake and output, blood tests like hematocrit, electrolyte and liver function test, hematocrit, electrolyte and liver function test, and imagine if complication like pleural effusion or thromboembolism are suspected. Third question is, what are the complication can arise during pregnancy with OHSS? Pregnancy with OHSS may have increased rise in preeclampsia, preterm delivery, and there is no consistent evidence of increased miscarriage. Now, what imaging is recommended for OHSS diagnosis? Pelvic ultrasound. This will detect ovarian size and ascites. Second is Doppler ultrasound. This will detect any ovarian torsion. Third is chest X-ray or CT scan. This will detect any pleural effusion or pulmonary complication in severe cases. What sign indicate recovery from OHSS? Diuresis. I have already talked about this. Diuresis means increased urine output. Second is decreased abdominal girth. Abdominal girth has decreased and weight has decreased. Weighing machine, abdominal girth and weight has decreased. Third is normalization of hematocrit has normalized and electrolyte level has normalized. Then what is the role of patient education in OHSS prevention and management? Empower patient to recognize symptoms early. We'll have to tell patient what symptoms are there so that they can recognize it early. Second is ensure they understand when and how to seek medical help. Third is reduce anxiety through clear, detailed explanation of treatment and prognosis. How should women with OHSS management on outpatient basis be monitored? See, on outpatient basis, urgent reviews required if symptoms worsens like increased abdominal pain or reduced urine output. So we'll have to tell the patient that if some symptoms worsen, you have to review. Second is, in absence of the worsening symptoms, review every 2 to 3 days. You'll have to come to the hospital every 2 to 3 days to review. If we are managing the patient on the outpatient benefit, we'll have to tell the patient these things, okay? Then repeated baseline lab test if severity increases, okay? And then hematocrit is a key indicator of hematocrit we'll have to do. It is a key indicator of intravascular volume depletion. Now, question is, what is the appropriate management for fluid balance in OHSS? Oral fluid intake guided by thrust is the most physiological approach in correcting dehydration. Persistent hematocrit despite IV colloid may require invasive monitoring with anesthesia input. If there is persistent hemoconcentration, even we give IV fluid, then also there is hemoconcentration. This will require invasive monitoring. Then avoid diuretics as they deplete intravascular volume. Diuretic we don't have to use, but may be used in multidisciplinary setting if oliguria persists after adequate fluid replacement and ascites drainage. Even if we have drained the ascites, we have done paracentesis, even and we are giving IV fluid in an adequate amount, even if then also there is oliguria or urine output is not improving, then we can give diuretics. Otherwise, we'll have to use diuretics very cautiously. How should risk of thromboembolism be managed? See, severe or critical OHSS prophylaxis of low molecular weight heparin is recommended. Duration for it is as seen by the patient risk factor and treatment outcome. Moderate OHSS will have to see the risk factor and consider low molecular weight heparin or stalking, anti-embolism stalking. Be alert for unusual neurologic symptoms as they may indicate thromboembolism even week after symptoms improvement. When is the surgical management indicated in OHSS? Surgery is only indicated in adnexal torsion, ovarian torsion, and ectopic pregnancy. Procedure must be performed by experienced surgeon to minimize risk. What are the benefit of early drainage in OHSS? Early drainage reduces the intra-abdominal pressure in moderate or severe OHSS. It may prevent disease progression and lower the risk of severe complication. Drainage of 2000 ml of ascitic fluid significantly reduces the intra-abdominal pressure and renal vascular resistance. What is the auto transfusion technique in OHSS management? See, Koike et al. What it does was ultrafiltration of ascitic fluid. It into the it like gave ultra filtration of ascitic fluid into the venous circulation. So this will reduce the hemoconcentration, improve the urine output, and promote the quicker recovery compared to conservative treatment. Another study, concentrated ultrafiltrate protein autotransfusion was done in another study. Ultrafiltrate protein auto transfusion was done. Okay, this replenished women's own albumin level and reduced infection allergy risk from the exogenous albumin. What is recommended duration of thromboprophylaxis in OHSS? No fixed agreement or duration of thromboprophylaxis. In cases of severe OHSS with pregnancy, thromboprophylaxis should be continued until the end of the first trimester. Okay, therapy should be tailored to individual risk factor and conception status. Specialized hematologist input can be helpful in individual treatment. What is the risk of delayed thrombosis in OHSS? Delayed thrombosis can occur week after OHSS resolution, particularly in pregnancy during first trimester. Symptoms are dizziness, vision loss, and neck pain indicative of arterial thrombosis. On suspicion of thrombosis, initiate therapeutic anticoagulant. If we are suspicious of thrombosis, we'll have to initiate therapeutic anticoagulant. Appropriate imaging will have to do and collaborate with hematology and maternal medicine specialist. Now, how should reproductive care address diverse patient need? Gynecologist service should be inclusive and sensitive to the individual whose gender identity may not align with their assigned sex. Okay, with diverse patient need, we'll have to look for the transgender patient, we'll have to be sensitive and inclusive to them. Okay, use appropriate language and ensure care meets the need of non-binary and trans individual. When should paracentesis be performed in outpatient setting? I have already talked about it. When there is severe abdominal discomfort, perform under ultrasound guidance. Why abdominal or transvaginal route? Rationale is reduce the symptoms and avoid hospital administration. This is about the outpatient setting. Okay. When should hospital admission be considered for OHSS patient? Indication for hospital admission is if the patient is unable to follow up regularly, and if it is unable to achieve pain control, if inadequate food intake is there due to nausea and vomiting, if the OHSS symptoms are worsening. Okay. When can diuretic be used in OHSS? We'll have to use the diuretic. Again, this question is being repeated. We have to use the diuretic carefully, and oliguria persists. Careful, consider diuretic only in when oliguria persists despite adequate fluid replacement, ascites causing the compression is already drained. Again, I'm telling that if ascites is already drained and IV fluid is maintaining, still if there is no urine, or if there is oliguria or anuria, then we'll have to do diuretic, but we'll have to do it in the present of multidisciplinary setting. When is multidisciplinary care essential in OHS? Required for cases like persistent hemoconcentration or low urine output despite colloid therapy. Critical OHSs with complication like ARDS and thromboembolism. Specialists involved are anesthetists, intensivists, and nephrologists. Rational ensure accurate monitoring and comprehensive management. How do complications differ between singleton and multiple pregnancy in OHSS? Singleton pregnancy, higher risk of prematurity and low birth weight. Multiple pregnancy, no additional risk compared to non-OHSS pregnancy. So OHSS affects singleton pregnancy more than multiple pregnancy in terms of complication. What information should be provided to the patients about OHSS? We'll have to give clear guidance on symptoms of the monitoring, like when to monitor, what are the early and progressive sign, when and how to report symptoms, and access to 24-hour contact should be there with the hospital. Okay, so this empowers the patient to seek timely care and avoid complication. What percentage of patient with severe OHSS should receive low molecular weight heparin? 100% of the patient with severe or critical OHS should receive the prescribed low molecular weight heparin unless contraindicated. This minimizes the risk of thromboembolism in high-risk patient. Thank you so much. Thank you.